Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. So today my topic is going to focus on trigger point injections. We had some coverage updates and some local coverage determinations, which are Medicare local policies, regarding the TPIs, and they became effective April 1st, or took effect April 1st, I should say. And they actually put some limitations not only on frequency guidelines, on appropriate diagnoses, so ICD-10s, but also, how many your patient can have. And I think a lot of people have forgotten to not only update their systems, their coding staff, their patients on what's happening. And it's really important because a lot of new policies out there are showing a lot of denials. I'm getting questions from my membership clients, and I'm also getting questions from people that are saying, wait, can you help us? And again, if you need any coding, billing, compliance, appeals, help, or anything like that, please go to my website at terryfletcher.net, go to services. The very first drop down is called the Coding Corner membership. There's an executive membership and also a regular membership. And that's what we do. Through email, we can ask or answer any of your coding questions based on our specialties. That's also on the website. And we help you with appeals. You get discounts if you need an audit. And we also, if you're an executive member, you can ask me anything, quarterly Zoom calls. So things like that, this can really help you with. And so I wanted to put that out there in case you are looking for something like that, just a go-to person if you need help. And we also give you cited references. And so if you're going back to your providers and saying, well, this is why you can or can't do something, it isn't just because Terry said, or you found this person on LinkedIn or Facebook, whatever you're using. It's because this is what CMS published guidance says, or this is the page, chapter, verse, and CPT, etc. So you do have that option. So I want to take a look at that. Okay, so back to the topic. When it comes to trigger point injections, now I'm referencing something that was also on Decision Health Part B News, but also I'm looking at the local coverage determination from Noridian. Now, First Coast Service Options and Novitas, they said that they aren't going to adopt the new policy as of April 1st, but I am told that Novitas is moving towards potentially adopting this policy in possibly September 1st. So eventually all of the MAC carriers are going to do that. So here's a couple of questions that have come in. Number one, if a patient has trigger points in different areas of the body, for example, the neck and the buttocks, can we treat both areas during one visit? Number two, are codes such as M54.2 cervicalgia or M54.59 other low back pain, those are both ICD-10 codes, covered under the new LCD? And number three, if a patient has trigger points in both shoulders or hips, can we report the service with a bilateral modifier 50? So the answer to all three questions is no, not anymore. So you have to make sure your providers and coders understand the overarching guidelines for trigger point injections that are now effective April 1st for 90% of the Medicare payers. And I am finding this extends to Medicare Advantage and some of the commercial plans. You also want to determine whether your MAC, so your Medicare Administrative Contractor, is one of the carriers that will implement the new LCD before it went into effect, or if you're seeing denials, now you'll know. But here's more details about the answer to each of those questions. So number one, the new LCD specifically prohibits trigger point injections in more than one anatomical region per session. So they say it's not considered medically reasonable or necessary to perform TPIs into multiple muscle groups in different anatomical regions during the same session. So that's huge. That's a real big one, especially for now. I've seen that spine surgeons are opting for TPIs for low back pain instead of their joint injections or doing their spine injections. So keep that in mind as well. Also remember to review the definition section of the LCD with your coders and not just the treating providers, because the LCD defines an anatomical region as an area of the body defined by structures which are palpable or visible, typically described as cervical, lumbar, scapular, thoracic, cephalic, and facial regions. So they're very specific to what they consider to be different regions, and they use that term. The LCD also defines a muscle group as, and I'm quoting, a group of muscles that are contiguous and share a common function. So they say the example, flexion, stabilization, or extension of a joint. Muscles that are widely separated anatomically and have different functions may be a separate muscle group. So you want to let your treating providers know that the LCD companion billing and coding article requires your documentation that clearly states the location of the trigger points and the muscle groups the provider is injecting. And to make sure you're prepared, you want to review 5 notes for trigger point injections by each provider who performs them. So if you find an anatomical information that's vague or missing, as you're doing your internal reviews, work with your providers to make sure they understand their documentation has to be supportive or equal to what the LCD is saying. Otherwise, the LCD is going to slap you in the face. It's going to say it's not here. So codes such as the M54.2, which I mentioned, cervicalgia, or M54.59, other low back pain, versus codes as G89.21 to 29, those are chronic pain, are not covered under the LCD, under the new LCD. The new policy covers 10 diagnoses codes from 2 code families. Okay, so tension type headaches, and that's from the G44.201 to G44.229, and then myalgia codes, M79.10 to M79.18. And diagnosis coding is another area that you really need to make sure that you're paying careful attention and communicating with your providers about, because if you can't get the diagnoses right, you're not going to have a link to payment. And a lot of times the trigger point injections from treating providers, they were falling into a lot of the non-covered categories, or they just felt that it was all over the place. Now, the third one, talking about the 50 modifier. So Medicare does not allow a 50 modifier with trigger point injections. It has a modifier indicator of 0, meaning 150% payment adjustment for bilateral does not apply if procedure is reported with a 50 or with RT-LT. So that they're basically saying whether or not your practice, if you're part of that new LCD for your Medicare carriers, do not use the 50 modifier. So the LCD companion article also kind of mimics that or echoes that as well. National Government Services is one of the 5 MACs that have issued, the uniform LCD, meaning that you have to use the initial code, for example, the 20552, and then an additional muscle group, 20553. So what was happening is that coders were trying to get allowables for the bilateral as a primary code, and you can't do that. I have the same thing that happens when we're doing certain peripheral angioplasties and stents in the venous area. So if it's non-venous, basically, or it's arterial, you code it differently than if it's venous. And so one would be add-on and one wouldn't. So it's interesting how this is kind of following that same kind of rule of thumb there, what they feel that is more appropriate from a payment perspective. Also, when I mention the patients, don't wait until your patients come in for their next trigger point injection that they have scheduled before explaining to them the new restrictions. Because some patients who regularly receive their TPI, trigger point injections, they assume that they can have them wherever, this hurts. And they need to understand the limitations on number of areas that a provider can treat in one visit, and the new frequency limitations that allow 3 trigger point injection sessions per patient in a rolling 12-month period. So, and also you need to make sure patients are understanding of what will not be covered under the new LCD. So really talk to your patients about this and your providers about this, because I've seen too many, wait and see approaches when it comes to what your, carriers say, or trying to submit a claim, or trying to appeal a claim when it's not appropriate. So you have to make sure that you have identified the issue, understand what's happening with that, and that your patients are aware of it too, not just your providers, but your patients. So even though that was a coding discussion, I had an interesting coding question come in from one of my membership clients, and I wanted to clarify because some things are getting lost in the translation. It was a telehealth question, even though it didn't come through that way. So it came through as a question about virtual supervision, which I'm just going to put it out there. I hate it because I don't think it's appropriate. It was actually something that was a gift given to us at the height of the pandemic in 2020, 4 years ago. And it was really so that supervising physicians and residents could see enough patients that were being admitted to the hospital without having to deal with the, supervision requirement. But now everybody's like, oh, I can use the, virtual supervision. I'm like, wait. This is not incident to you. Guys have to be careful and step back. Well, the question came in as far as, physicians want to be able to have everything billed under their provider number, their UPIN, because they want the full allowable instead of allowing their nurse practitioners or PAs to bill it and getting that 85% allowable instead of that full allowable, which you cannot report services just based on money. You have to report on what you do. And so the question came in as far as, well, if my provider is providing virtual supervision because he wants to be at, 2 places at once, is that okay then to do that? Well, remember, split or shared visits is different than supervision requirements, and there's no incident to in the hospital. So the person that's billing it has to have that face-to-face component for hospital E&M services. And there's a reason. If you're sick enough to be in the hospital, you need to be seen by a provider. Now, there is work involved that can be non-face-to-face for that patient, but it doesn't have anything to do with virtual supervision. So remember, that's not a component of split or shared visit. It's a substantive portion or the time element, and then who had the face-to-face, not the virtual supervision, who had the face-to-face with the patient. Where the pandemic's over. It's been over for a year. That's different now. And so you're kind of mixing them up. And so what it would be is if you're trying to bill out under, telehealth, where everything was set up, telehealth in the hospital, unfortunately, is still available. You have to put down why you're using telehealth, why you couldn't be there. Trying to be at 2 places at once is not a reason, just so you know. That would not sit well with an administrative law judge if that's your reasoning. But if that is what you're doing, and even though technically you can have that option to do that, you would have to, explain why you can't be there. And it would have to be still you doing the substantive portion. It would have to be set up by the hospital so they can get their facility amount for that. And you would still have the facility place of service of O2, and you'd be cut because you'd be cut anyway, at least 20%. So it'd be less than you'd get if you just let your staff bill out that split or shared visit. If it is a nurse practitioner, PA, or clinical nurse specialist. So be careful when you ask questions that actually aren't the question that you're really trying to ask. So the question came up, can we basically slide by our virtual supervision and get 100% of our split shared visits, when the question actually is the doctor, using virtual supervision, is that considered appropriate for telehealth? And the answer, the latter, is that you would it's not. You'd have to basically provide that telehealth visit. Can your mid-level provider provide some of the services? Sure, but if you want it billed out under you, then you have to make sure that it also is specific place of service, that you're using the hospital equipment. The hospital can get, their either Q code if it's outpatient or their facility code if it's inpatient, and make sure that they are also part of that process, because you're using their technology to be able to see the patient from that virtual telehealth standpoint. And you have to document also what platform you used, why you're seeing them, for that, and that the patient is aware that it's still, full out of pocket for them. But you're going to get cut anyway because you're dealing with facility rates. You're not there. You don't get the work value for that. So if the lesson to me for this is, if your physician can't be in the hospital on a split shared visit, then let your mid-levels handle it. That's what they're there for. That's why you trust them. That's why they're considered physician extenders. So, they're not RNs, they're nurse practitioners and PAs. If you don't have that trust factor with those kinds of providers, then you need to go provide the service yourself. So just be careful when you try to cross-reference one rule for another when it doesn't apply to that particular service. Okay, so I know it's heating up around the country. Just a public service announcement. Make sure you're using your sunscreen, your sunblock. I'm getting quite the tan being in my swimming pool. Every day now, I've been in for 58 days straight. We haven't had any rain here, so I've been lucky. But it's helpful because I'm really trying to move more, continue in my weight loss journey, stay healthy, and just, eat right. And hopefully everybody is trying to do the same and really, be on the healthy trail, because you never know how long you have. So hopefully everyone's doing that. But it is June. We're already starting to see some record heat. I know today that I'm recording, it's going to be 94 in California, but it is summertime. So this is what happens in the summertime. So just be safe out there. Make sure you're staying cool if you can and protect yourself from the sun. And everyone, have a great rest of your week. Make it a great day. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.